Okay, hi guys, everyone. Are you there? Can you see me? Can you hear me? Welcome to this dermatology session. I'm Dr. Saurabh Jindal. Let's dive into dermatology. Just check, please. Audio, videos. Is the audio okay? Video okay? Are you able to hear me well? Yeah. Just give me 1 minute. I can see some white cast coming on my head, like a leukotrichia. I just wipe it off. Give me 1 second, please. Not audible? Just check now. Am I not audible? No problem, no problem. That's what we do this. Okay, just check everything is okay. Now audio is there. Now okay. I'm sorry about this white cast. I'm sorry about this white cast now, which is kind of, I think I'll just see. I don't think I can do too much about it. So sorry for that. Okay. I'll just tilt the camera a bit. Okay. ठीक है चलो करें शुरू. Okay. So what I was saying, sorry for the delay. It was just some tech issues that sometimes crop up against our wish. So sorry for that. Okay. Chalo. So what I've done today is a bit different than what I've done in the one shot session. And when the one shot, we did a lot of charts. Okay, कि ऐसा है तो go here, ऐसा है तो go here, right? Okay. Now, what we'll do today is something different. In the INICET, what I've seen is they almost always focus on previous topics. It's going to be something or the other which is going to be linked to whatever they've already asked. So kind of I picked up almost all the exams twice a year, right? So we have about 10 papers that we can address, 10 papers that we can address, okay, right? Voice is breaking, okay. Just check, bache, is the voice okay? Is the voice okay? I think it should be okay. Voice is breaking, should be okay. Just check. Voice is breaking in between, okay, no problem. Somebody saying voice is fine, just check, no problem, bache. We'll take our time. We want to sort out all the stuff. Check, please check. Check now. Is it okay? Voice is good, sir. Okay, chalo. ठीक है. Fine. Thank you. Let's go ahead. Okay. Now, what I've done, as I said, I've picked up 10 papers. Okay. And I'll run through everything and I'll run through all the topics that are there. I'll tell you all the pickup points. I'll tell you all the magic points. I'll tell you how to differentiate. We'll look at images. We'll look at everything that's happened in the last 4 to 5 years in dermatology and INICET. And we are very confident. I'm very confident that a lot of it comes from there. Okay. I understand that INICET is a conceptual exam, but somehow, and that's great that they actually want to really pick up something which they've already asked. So we are going to do from there, right? Chalo. Let's start, bacha. Let's start. Okay. Now, which type of vitiligo progressive initially, then becomes static? Okay. I'm going to pick up one topic and we'll finish all the MCQs there. Which type of vitiligo is progressive initially and then becomes static? Can you just keep on answering and then I'll explain? Can you keep on answering? Can you keep on answering, please? Keep on firing the answers. Keep on firing the answers. Which type of vitiligo is progressive initially and then becomes static? We're picking up all the MCQs now, which have actually been asked. These are real MCQs. These are not a fiction MCQ. They are real MCQs. This was asked in your recent most AIMS exam, in the INICET exam. The answer is segmental vitiligo. The answer is segmental vitiligo. Let's look at all the MCQs that are there on this particular topic of segmental. Now, what is segmental vitiligo? Remember, and this you can keep on writing with me. Segmental vitiligo is the only vitiligo along dermatome. Write down this. Keep on listening, keep on writing, okay? The only vitiligo along dermatome. We also know there's one more disease along dermatome, and that's called herpes zoster. This is going to be a very high-yield topic. I'm going to move laterally and keep on giving you other MCQ which is also connected to that topic. So you will now look at only two diseases coming along the dermatome. One is going to be the segmental vitiligo, right? One is going to be called herpes zoster. Some of you are saying the voice is breaking. Can you confirm? I think a lot of students are saying voice is okay. Is the voice breaking? Is the voice okay? Because if some of you can hear it, then obviously then the problem is not from our end, right? Okay. Let me then, is the voice breaking, bache? Voice is okay. Some people are saying voice is okay. Okay. So herpes zoster is also a disease along dermatomes. Okay, segment is also down. This is the segmental vitiligo. Okay, this is a segmental vitiligo. Now, what segmental does is it starts from one nerve end and increases along the entire nerve end, and it stops growing. Stops growing when the line is completely covered. When the line is completely covered, right? When the line is completely covered, nerve is complete, that's called segmental vitiligo. Got this, please? Segmental vitiligo, right? Now, what are the other types of vitiligo that we have, and what are the MCQs that actually come on it? We'll go laterally from there as well. Okay, we'll go laterally from there as well. Okay, now the typical vitiligo, the most, write down the MCQs, please. Most common vitiligo, we'll go laterally now. Okay, most common vitiligo, remember, is vitiligo vulgaris. Vitiligo vulgaris. Vitiligo vulgaris. Okay, indication for surgery. Indication for surgery. Okay, indications for surgery. Okay, is stable vitiligo. Stable vitiligo, which is defined as vitiligo not increasing since 2 years. Some people say 3 years, some people say 1 year, but 2 years is a good enough time. Stable vitiligo, if it's there, then you can do surgery. We can do surgery in that particular. Poor prognosis factor. Poor prognosis factor. One is called acral vitiligo. Acral vitiligo. Acral vitiligo. Okay, acral means on the ends of the body, like your fingers and your toes. Okay, leukotrichia. Okay, leukotrichia is poor prognostic. Associated autoimmune disease, let's say somebody has got a thyroid disease. Okay, that would be a poor prognostic factor. Long duration vitiligo, if the vitiligo is old, then we are in trouble. Okay, and vitiligo in more than 50% of the body. Okay, these are called as poor prognostic factors. Okay, poor prognostic factors. Okay, poor prognostic factors, remember this. Poor prognostic factors: acral, leukotrichia, autoimmune disease, long standing, and more than 50%. Got this, please? Everybody, right? So we are going to do this. Okay, we'll go to a question, I'll give you the answer, I'll give you lateral stuff. We'll be quick, obviously, we don't want to really waste time. So, but this is going to be a high yield stuff. This is where the MCQs come from. Clear ho gaya? Clear ho gaya? Everybody, right? Everybody okay with this? Clear? Okay. Best phototherapy in vitiligo is NB-UVB, narrowband UVB. Okay. Safest in pregnancy. Safest in pregnancy. Safest in children is narrowband UVB with a wavelength of 311 nanometer. Okay. 311 nanometer. Everybody got this? 311 nanometer phototherapy. Clear? Okay. Everybody okay with this? Okay. This is called segmental vitiligo. Linear, stops growing when the line is completely covered. Okay? Okay. Question number 2. Okay? Question number 2. Question number 2. Match the following. Match the following. Match the following. Read this question. Tell me the answer, bache. Read this question. Tell me the answer, bache. I'll explain everything, but just tell me the answer now. Just tell me the answer. Patch test. Okay. Now let me just read this up. It's been asked too many number of times, so I think we should really cover it properly now. We should really cover it properly. Okay. Now see, patch testing, right? Now patch testing is a classical test for ACD, allergic contact dermatitis. Okay. So this will match with contact dermatitis. Okay. Slit skin smear, I'll tell you that also. It will match with leprosy. Biopsy and KVH. In fact, it's going to be completely lateral contacts now. Okay. 1A, okay, 2B, 3C, 4D. It's going to be the third option. It's going to be the third option. Let me give you all the MCQs on these points. All the MCQs on these points. Okay. Now, patch test. Write down, please. Patch testing. Write down, it's a delayed CMI, delayed cell mediated immunity type. Okay. Best reading for patch test. See, I'm assuming that all of you know dermatology, right? That's the assumption for this particular session, that you know stuff. So I'm not going to really go into the depth, into the detailed conceptual stuff. but I'm going to tell you all the leading MCQs here. Best reading at day 4 of patch application. Okay, best reading on day 4 of patch application. It's a classical diagnostic test for allergic contact dermatitis. Allergic contact dermatitis. There's a modification of the patch test right down called as photo patch test that is done in ABCD. Airborne contact dermatitis. Airborne contact dermatitis, also called as Parthenium dermatitis in farmers. Parthenium dermatitis in farmers, and that's called photo patch test. Most common allergen in India, most common allergen in India is nickel. Okay, most common allergen in India. Okay, most common irritant in India. Okay, most common irritant in India is soaps and detergents. Okay, soaps and detergents. These are your classical MCQs for photo patch testing, irritant contact, allergic contact. Clear ho gaya? Everybody got this? Okay. Now the second test that we saw in the chart was slit skin smear. SSS. Always remember SSS is taken from the ear lobes and taken from the skin lesions, and typically we do it for leprosy. Okay, remember always it's negative in paucibacillary leprosy and positive in multibacillary leprosy. PBMB, classical PBMB, SSS. Stain used is ZN stain. Stain used in SSS, stain is SSS, is Zeal-Nielsen stain. Zeal-Nielsen stain. What are the other stain for leprosy? Remember fight stain. Remember fight stain. Okay, fight, FITE, fight stain. Okay, there's one test, one more entry in the table is lupus vulgaris. Remember there are two tests, one is called diascopy, one is called biopsy. In biopsy we get non-caseating granulomas. Okay, non-caseating granulomas. Okay, diascopy gives you apple jelly nodules. It gives you apple jelly nodules. This is a type of skin tuberculosis. It's a sign of, it's a type of, skin tuberculosis. Okay. KH mount is done for tinea. KH mount is also done for pityriasis versicolor. Write down the indication of KH mount. Very important topic. KH mount, tinea. KH mount, pityriasis versicolor. KH mount in this gives you what is called as spaghetti meatball. Okay, spaghetti meatball pattern. There is also a whiff test in KOH, which is for bacterial vagina. I'm not writing the full forms, okay, bache? For lack of time, please don't expect me to write the full forms. Bacterial vaginosis, okay, whiff test. We also do it for scabies mite demonstration. Scabies mite demonstration, KOH mount, okay. That is pityriasis versicolor, tinea, whiff test, scabies mite demonstration, KOH mount we can do. So can you now understand? See how much information I've given you in 2 MCQs. We are going so much laterally. I'm trying to give you lateral information. We are not only going straight in the MCQs, we're also going laterally in the MCQs. Are you with me on this? Are you able to understand the way I'm going to do this? I hope you got an idea on how this is going to be done. This is not a teaching class. This is an MCQ solving class. I'm going to give you lateral here and there and keep on writing your notes. Make notes like that. Okay. Right. Question number 3, bache. Which doesn't cause annular plaque. These are real MCQ. This was the recent most INICET exam. So we are doing the real MCQs. As I'm repeating, it's not a fictitious made up MCQ. All of them, whatever MCQs we are going to discuss today, word by word, all of it have been already asked in your exams. Okay. Which doesn't cause annular plaque. Okay, which doesn't cause annular plaque. To understand this, let me give you all the morphologies first. I'm going to give you the answer very soon, but let me tell you the morphology. What is annular first? Okay, the word annular, also called as ring. Okay, when we talk about ring, this is what a ring means. Every ring has a central clearing. Okay, and an edge which is active. And an edge, this is called a annular or a ring lesion in dermatology. Okay, now what are the causes for annular lesion in dermatology. You always remember three causes. One is BB leprosy, borderline leprosy. Okay. Second is tinea. Always remember tinea. Very, very important. Tinea. Okay. Tinea. Clear? Okay. Third is Pityriasis rosea. Pityriasis rosea. Okay. Pityriasis rosea. ठीक है, Pityriasis rosea. Clear हो गया? I'll tell you what Pityriasis rosea actually means. Okay, and then there is a rare disease called as porokeratosis. Okay, which is also going to create an annular lesion. I'll talk about them. Okay, talk about them. So these are four diseases you have to remember for this annular morphology. Annular morphology. Okay, in this remember one thing, that Pityriasis rosea and tinea both have annular with a scale on the edge. Scale on the edge. Okay, whereas in porokeratosis and BB Hansen, it's annular without a scale. Both are annular lesions. All four are annular lesions. One is with scale on the edge, one is without scale on the edge. So BB Hansen, porokeratosis, you don't have to know too much about porokeratosis. It's basically a keratinization disorder where you get a ring-shaped lesion with a central clearing. There's a bit of heightened keratotic edge on the periphery in porokeratosis. BB Hansen is borderline Hansen. Okay, now, so this is called the annular ring lesion. Okay, now this is called discoid. Discoid means like a coin, meaning there is no clearing in the center. Can you see this? No clearing in the center. It's just a complete coin shaped lesion. There are two diseases you have to know where this happens. One is called discoid eczema, bache. Okay, one is called discoid lupus erythematosus, DLE. Okay, DLE and discoid eczema. Both are basically eczema, both are discoid lesions, no clearing in the center. Okay, can you see the DLE lesion? No clearing in the center. The scale has been called as carpet tack scale, and we already know it creates scarring alopecia. It creates scarring alopecia. It's a sun-induced autoimmune disease. No clearing in the center. Okay. Okay. Now we have another morphology called as target. Target is usually going to be three zones like this. Like, can you see its target? This is seen in two disorders. One is called erythema multiforme. One is called as erythema chronicum migrans. So third morphology, target, erythema multiforme, erythema chronicum migrans. EM, the most common cause is herpes simplex virus type 1. ECM, the cause is a hard tick bite giving you Borrelia. So remember two causes from the INICET perspective. Herpes simplex virus 1 creating target lesion erythema multiforme, and ECM, which is Borrelia disease, which is going to give you Lyme's disease, erythema chronicum migrans. Okay? So this is what a target lesion means. One zone, second zone, third zone. Three zones typically for target morphology. Target morphology, right? If I then go back on the question now, okay, which doesn't cause annular lesion, the answer would be the third one. This creates what is called as a wheal. Okay, now wheal is a sign of mast cell rupture. Okay, it's a sign of mast cell rupture, and wheal is a triad of three things: itch, edema, and redness on the skin, and it's because of histamine and leukotriene basically coming out of your skin, Yes, are you with me on this? I hope the speed is okay. I hope it's not too fast. Are you able to understand? See, I'm not going to give you any junk words today. Okay, it's going to be just drilling and drilling and drilling as much as the words I can fill in into the session. Okay, and I'll try to do that. I'll try to go laterally. I'll try to give you as many possibilities of variations of the same questions and see if I can give you other answers from the same question and explain the other options as well as the answer, right? I'll give you the other options as well. I'll tell you the explanation for that. Okay, clear? Okay, which anti-leprosy drug causes pigmentation? Okay, the answer is clofazimine. Clofazimine is going to give you red-brown pigmentation. Right? Okay. Now clofazimine has two doses. One is called the MDT dose, which is which everybody gets. which is 300 milligram monthly, once a month, and 50 milligram daily. This is the MDT dose. Then it is the drug of choice for recurrent ENLs. Okay, recurrent ENLs. In that, the dose is 300 daily for 3 months, right? 200 daily for 3 months and 100 milligram daily for 3 months. Can you see the higher dose? Okay, got it? 3 months, 3 months, 3 months. So in the recurrent ENL, there's a lot of chance for this red-brown pigmentation because you're giving a very high dose. Fortunately, it's reversible. When the drug is stopped, the disease vanishes. You also have to know one more. One is called arsenic pigmentation. That's called raindrop pigmentation. One is minocycline pigmentation, which is a blue pigmentation and usually happens in people who are going to be given minocycline for acne, for example, right? Okay, right. Now, rifampicin radon is the most potent drug, okay, for leprosy. It is a bactericidal drug, okay. It's the most potent drug and bactericidal. It's given once a month, okay. Dapsone radon, side effects of dapsone: hemolysis, and hepatitis. So remember the 2H: hemolysis and hepatitis. Hemolysis and hepatitis. ठीक है? Clear हो गया? Right? Everybody clear हो गया? Which anti-leprosy drug causes pigmentation? So it's Hansepran, which is clofazimine. You can see this pigmentation. It's going to obviously be not very good to have this pigmentation. It stays and it makes the person quite dark. Clear? Okay. Which STD is drug resistant? This was again asked quite recently. The answer would be gonorrhea. Now, gonococcus is almost having a lot of MDR strains, multi-drug resistance, right? Especially to quinolones. Okay, it's getting a lot of drug resistance, okay, to quinolone, which was earlier given. Now, the present guidelines ask you to give ceftriaxone, injectable, or cefixime, oral. Okay, this is the usual treatment for gonorrhea. We usually add doxycycline for co-infection with chlamydia. Okay, co-infection, usually this happens. Sometimes both these pathogens can go in through the sexual route, which is urethritis and urethral discharge. So you want to now give cefixime, ceftriaxone, add some degree of chlamydia coverage with doxycycline for 7 days time. So it's going to be 1 dose of ceftriaxone or 1 dose of cefixime, either of them, plus add Lichen, add some degree of doxycycline coverage. Otherwise, what happens is the gonococcus will go away, but the others don't really seem to go, right? Okay. Now, gonococcus causes carrier state in females. In females, it causes a lot of cervicitis. Okay. In males, it creates urethritis. In males, it creates urethritis. Females, it is going to create cervicitis. Cervicitis. Got this, please? Drug of choice for syphilis is benzathine penicillin. Benzathine penicillin. DOC. Benzathine penicillin. Okay? Let's give the drug of choices now. Okay. Syphilis. Okay. Drug of choice. Syphilis, benzathine penicillin. Okay. Drug of choice, benzathine penicillin. Chancroid, drug of choice, azithromycin. Donovanosis, doxycycline or azithromycin. Okay, in this azithromycin is preferred. Okay, LGV, doxycycline. Okay, LGV, doxycycline. Herpes genitalis, it's going to be acyclovir. It's going to be acyclovir. Got this, please? Okay. Clear, everybody? Okay? Acyclovir. Candida, fluconazole. Okay? Bacteriogenesis and trichomonas. It could be secnidazole. or tinidazole or metronidazole. This is preferred secondazole because it has the least nausea potential. So everybody understood, the entire STD is covered. The drug of choices for all STDs should be simple enough for you to do now. Okay? Okay. Sixth question, please. Try and answer, bache. Try and answer. Try and answer. Try and answer. A 40-year-old male comes, 45-year-old male comes with recurrent blisters and oral ulcers for the last 3 years. The histology has shown. The diagnosis is. There's a very typical row of tombstones. ROT means row of tombstone appearance. You should be able to identify the basal layers, okay? And this is the suprabasal area. It's a very simple question. I don't think we have too much trouble on identifying this for all of you. It's something which is, if it comes, then you will be very happy. A simple question aa gaya, na? Something you'll be happy to do that, okay? So it's going to be obviously pemphigus vulgaris. You can see this two things. We call this mucocutaneous pemphigus vulgaris. Mucocutaneous pemphigus vulgaris. Okay? DH, it's going to be a dermal papilla blister. Okay, dermal papilla blister. I'm going to draw that for you. Okay, pemphigus vulgaris. Remember, suprabasal. I'm going to give you the points now. Suprabasal blisters with acantholysis. Okay, suprabasal acantholysis. Pemphigus foliaceus, subcorneal with acantholysis. Okay, I'm going to give you exact points. Bullous pemphigoid, subepidermal, no acantholysis, and a lot of eosinophils. This is a very important point. Eosinophils, okay, and this eosinophil is a reason for the lot of itching and also urticaria like lesions that you get in bullous pemphigoid. That eosinophil is important. Dermatitis apertiformis, again subepidermal, but guess what? There's only in the papilla. Only in the papilla blister. Okay, blister only in the papilla and not eosinophil. This time you're going to give neutrophil. You're going to get a lot of neutrophil. This neutrophil gives you a lot of itching this time, and the drug of choice that we give here to remove it is dapsone. Is going to be dapsone. So these are the 4 broad diseases where a lot of questions come. Bullous pemphigoid, DH, okay, and the last one is Haley. Last one is Haley. ठीक है? Haley is again suprabasal. Again we have acantholysis. Okay, so it's almost like pemphigus. The only thing is this is congenital, whereas pemphigus is an autoimmune disease. So that's what we need to know. Okay, very typical suprabasal acantholytic disorder is Haley disease. Understood all the histopathologies for all autoimmune diseases that we have, along with congenital diseases that we have. The common ones I have said. We don't want to go to all the big stuff and details. Okay, okay. A patient comes with skin lesions. Investigation. What test is this? This has again been asked quite frequently for you. This is usually a DIF. Okay, this is usually a DIF. Direct immunofluorescence is going to give you this. Okay, this DIF is a linear deposit. Okay, linear deposit along the dermoepidermal junction. Okay, this is what you can see here. We can see this here, right? Clear ho gaya? Okay. Now this linear deposit, if it's going to be IgG, right, then we'll call it bullous pemphigoid and EBA. If the same linear deposit is with IgA, it's going to be called as linear IgA disease. Okay, linear IgA disease. Okay, so it's a test to pick up antibodies, and all the fluorescence is going to be green in color, and that's typically something that we usually look at in DIF. It's basically a tissue sample. You look at the bound antibodies. In indirect fluorescence, indirect immunofluorescence, you pick up antibodies in the blood. Okay, blood में जो circulating antibodies, that's what you pick up. Here वो नहीं होता. You want to pick up the bound antibodies, and the fluorescent dye is put, and the green color then comes, and that's a DIF antibody test that we get. This is only a test for autoimmune blistering disorders. It's a test for autoimmune blistering disorders, right? Autoimmune blistering disorders. Okay, it could be pemphigus, it could be something. And one important understanding for you, if this is the blister of DIF, then the biopsy for DIF is taken not from the blister, is taken from what is called as perilesional skin, this area, perilesional skin. We don't have to really know why. Okay, that's beyond the scope of today. But remember, histopathology is taken from the blister. Histopath takes sample from the blister. Okay, but for DIF, the biopsy taken from normal skin, which is right next to the blister, that's called perilesional skin. Normal looking skin that also has antibodies, you can pick it up there much better, because if you take the blister, the antibodies can actually flow off. Okay, so for antibody detection, just go on the side, from normal looking skin. Clear ho gaya? Everybody able to understand, bache? Are you able to judge and understand this, please? Okay, right, this is what we mean. You can see this fishnet fluorescence here. Okay, we know this fishnet fluorescence is a pemphigus fluorescence of IgG and C3. Okay, linear pattern we already discussed, and this is called the dermal papilla pattern, which we just discussed right now. Okay, this is the papilla, this is IgA in a granular pattern in the papilla, and this is classical of dermatitis herpetiformis, DH. ठीक है, ये होता है DH. ठीक है, DH, dermatitis herpetiformis, ठीक है, clear? Yes. Okay, now which of the following shows non-scarring alopecia? Okay, which of the following shows all except? Okay, all except. So this is basically you want to pick up things which are scarring alopecia, obviously, right? So alopecia areata is non-scarring, another film non-scarring, this is non-scarring, the answer is the fourth one. Frontal fibrosing. Now the word fibrosing itself is a giveaway clue. This is basically a fibrotic process on the frontal areas where there's a bit of damage to the hair follicles permanently, and obviously then the hair, okay, will not really remain. Hai? So this is going to be the fourth one. Clear? Clear? Okay. Now alopecia areata, let's look at a few quick MCQs on this. Okay. Alopecia areata, right on. Complete hair loss, remember that. Okay. In contrast, trichotillomania is incomplete hair loss. Okay. Incomplete hair loss. That's the important understanding. Okay. This is going to be sparing of white hairs because antigen is only melanin. Not like that. Okay, not this, not like that. Okay, meaning it's not going to be, it involves all hairs. Okay, this is going to be not on the dominant hand side. Okay, this is on the dominant hand side. मतलब जहां पे भी you can pull, you are pulling from the dominant hand side, pulling from the dominant hand side. ठीक है, clear हो गया? Right, that is a very important difference between areata versus trichotillomania. That's how you would differentiate. Okay, there's going to be hemorrhage on biopsy. There's going to be T cells on biopsy, right? T cells on biopsy. Clear ho gaya difference? Okay. Anagen effluvium, always remember there's going to be history of chemo. That's something that will always feel fine. In telogen effluvium, TE, telogen effluvium, there's going to be history of anemia, any severe fever in the past. Okay, these are two things, or hypothyroidism. So look for this in MCQs on telogen effluvium. Okay, so now quickly we have covered 4 causes. 2 of this is, all 4 are non-scarring alopecias. Non-scarring alopecia. Clear? Yes? Okay. Ninth question is important. Okay. I am removing my own self so that you can see the image properly. Okay. A 25-year-old patient comes with lesion on the trunk as shown. The correct option here would be, now this image, this one is called the Herald patch. Okay, and this is what is annular. I already told you. Peters rosea is the disease that we are diagnosing here. Herald patch, also called as a mother patch. This is the first patch that actually comes first, and that usually comes on the trunk. Also remember, it's always along the rib lines. Okay? And the rest of the leaves will also come like this along the rib lines in a V pattern like this. ठीक है, इसको बोलते हैं fir tree. This is what you need to remember. Okay, so the answer is this one, fir tree. Okay, this is not lichen planus because lichen planus is going to be purple. This is not purple, right? And this is very classical HHV 7, human herpes virus 7 infection. What is the treatment? Not required. It's self-limiting. It usually goes away on its own. It usually goes away on its own. That's a typical collarette pattern. Collarette means the scales are always going to be only on the periphery. That is called a collarette scale, edge scale, like a collar of scales. That's called collarette scale. Christmas tree pattern. We can understand the Christmas tree pattern there. Okay? Okay. Now, question number 10, bache. A 60-year-old man presents with ulcers on the lateral side of the tongue. The diagnosis. Tell me, bache. Easy question. Should not be difficult to diagnose. Tell me the question. Tell me the answer, bache. This is very typical basal cell. We call this rodent ulcer. Always look for nose in every question on BCC. Okay. Radon, it's got a great prognosis. Okay. That's called rodent ulcer. And always remember the edge. Beaded, rolled, pearly. This might be a revision for some of you, but it's okay. We can even revise. And it bleeds. Okay. Because a lot of vascularity and it can bleed quite a bit. Okay, that's called typical BC. This old man is usually going to be chronic ultraviolet light exposure, which creates this rodent behavior. It's the most common cancer in immunocompetent people. Most common cancer in immunocompetent people. Typical rodent ulcer, good prognosis. Metastasis is very, very rare, and surgical excision is usually done with surgery. Okay, okay, okay. Now this is 11th. Important question. 12-year-old girl, obese girl, discoloration of the neck and axilla. Now look at this. There's a term, we call this velvety pigmentation. See the word please. Velvety, like how your velvet, your carpet, like how that velvety pigmentation will be there. That's called velvety. Now this is because of thick skin of acanthosis nigricans. Acanthosis nigricans. Acanthosis nigricans. Okay. What is the risk factor is diabetes. You can get insulin resistance, diabetes, and that's a very common metabolic syndrome association. Let me give you some MCQs here. Acanthosis nigricans, remember, is a misnomer. Okay, because there is no acanthosis in acanthosis nigricans. Okay, what are the causes? One cause is lifestyle factors, okay, especially insulin resistance. Okay, and this insulin resistance causes diabetes, non-alcoholic fatty liver disease, hypertension, hyperlipidemia, and central obesity. This is called metabolic syndrome. Okay, metabolic syndrome. Okay, metabolic syndrome, metabolic syndrome. It is also a paraneoplastic phenomena. It can also come after GI, with GI malignancies. Okay, it can come with esophageal malignancy, for example. So this is going to be a paraneoplastic phenomena because many of these cancers release growth factors. Those growth factors thicken up the epidermis, skin, and then skin becomes black. So that can also be there, or it can be insulin resistance as well. Insulin resistance as well. Got this, please? Yes, everybody? Okay. All right. Now, 12th, an immunocompromised individual presents with corrugated. This is an important question. Huh? Corrugated. Corrugated means something like this, called corrugated. Corrugated. White lesion side of the tongue which does not wipe off. the case could be. Now, whenever you have a DD of oral white lesions, only look at three: oral candidiasis, okay, then oral lichen planus, okay, leukoplakia, okay, and we're writing four actually, fourth, OHL, oral hairy leukoplakia, okay. Oral candidiasis will have usually a white area, uniform area, white uniform plaques, but can be removed by a spatula. Can be removed by a, you can scrape it off, okay. LP is white crisscross, white lacy pattern, okay, lacy pattern. Look, so oral candidiasis is a uniform area, as I'm just drawing here, uniform area, but can be scraped off. Leukoplakia is also a uniform area, exactly like oral candidiasis, again white uniform, but cannot be scraped. Got it? Cannot be scraped. Oral hairy leukoplakia is this, corrugated. It's white corrugated on the sides of the tongue. It's always on the sides of the tongue. Okay, always on the side of the tongue, and it is not scrapable again. And not scrapable again. This is seen in Epstein-Barr virus, especially in HIV patients. Okay, HIV patients. So these are the DDs for 4 white areas in the mouth. I hope you got that. 4 white areas in the mouth. 4 white areas in the mouth. So the answer would be EBV. Abstain. HSV1 causes vesicles. We call them grouped vesicles, bache. We call them grouped vesicles. If it's on the lip, it's usually HSV1. If it's on the genitals, the grouped vesicles, it's going to be HSV2. Okay. Canada, I told you this is going to create Kaposi sarcoma. Okay. EBV is what we just saw, Epstein-Barr virus. Okay, can you see this? Corrugated white lines on the sides of the tongue. It's asymptomatic usually. It's a marker of Epstein-Barr virus in HIV. This doesn't really specifically require any treatment, but it's a marker of HIV positive status. Patient might not even know about it initially. Okay? Okay. Now, okay, this is just, so just to show you, this is the oral candidiasis. Can you see oral OC? This is leukoplakia. Okay, and this is the white streaks of oral lichen planus. If I zoom in, you can see this white streaky pattern of oral lichen planus. If I go up, this is going to be uniform white. Okay, oral candidiasis is also uniform white of leukoplakia, but one is scrapable, one is not really scrapable. Okay, clear? Okay. 13th, 18-year-old baby was brought with neonatal meningitis, vesicles on the trunk and the limb, mother ulcers but resolved now, multinuclear giants. Everything is supportive of herpes simplex virus. Okay, now just to show you, HSV2 causes first of all a vesicle. See the sequence, vesicles. Okay, this vesicle will give you an ulcer because it ruptures and then it heals, but then it recurs. So it keeps on doing like that. Vesicle, ulcer, heals. Vesicle, ulcer, heals. Now this is usually on the genitalia. Clear? Now because of that, the mother can pass it on to the baby. Baby will have disseminated herpes infection. Okay? Disseminated herpes simplex infection, which is now creating for the baby neonatal meningitis and vesicles on the trunk. Multinuclear giant cells basically means that there will be multinucleate giant cells like this, MNG. Okay, multinucleate giant cells in dermatology is typically there with herpes. Typically there with herpes. Got this, everybody? Okay. Now I'm going to make a great chart for you. See if you can make out the histopathology here. Okay, this should be now easy for you. Okay, just see what I'm going to develop for you now. Okay. Herpes simplex virus, multinucleate giant cells like this, seen on Zank smear. Okay, seen on Zank smear. If the question is pemphigus, you will find single cell, single nucleus. Okay, again on a Zank smear. Okay. If the question is on MCV, you will find in the epidermis a lot of these red colored bodies. Okay. Red colored bodies like this. Red colored bodies. Okay. These are red colored bodies. These are called as Henderson-Peterson body. Okay. This is going to be eosinophilic, remember. Okay. If it's going to be HPV, okay, HPV, we're going to have a cell and a nucleus and a perinuclear halo. Perinuclear halo. Okay. इसको हम बोलते हैं कोइलोसाइट. So these are the four things that you can remember. Okay. HPV, MCV, herpes and pemphigus. So this is going to be a good revision and summary for these bodies that you can get in viruses versus pemphigus. Okay. So answer obviously would be herpes simplex. This is just to show you that single nucleus, single cell would be herpes, multiple nuclei inside a single cell, acantholytic cells, both of them on Zank smear. The left one is herpes, the right one is pemphigus. Clear? All right. Okay. 14th. Let's go to 14th now. Okay. A obese female with BMI 29, hirsutism score of 6, irregular menses, comes to you, testosterone, you will all accept. Now the BMI guidelines are when the BMI goes to more than 25. Okay. We call it, see, below 23. One second, I'll write it down. Below 23 is going to be normal. Okay. 23 to 25 is going to be called as overweight. Okay, and above 25 is going to be called as obesity. Okay, so it's 29 body mass index. Obviously, it's an obese. Hirsutism score means it's going to be a hirsutism with thick facial hairs. Okay, not irregular menses. So obviously, this is polycystic ovary disease. Okay, you will advise all except. Now, OC pill only is the worst choice, because once you give only medicines without telling her anything about lifestyle, about anything, if you give only OC pill, right, it says, it's a weirdly worded question. It's not a very good question, but I had to put it because actually it was asked. So when you say only, okay, that means you're not doing anything else, right? You're actually mentioning that the doctor is not told about lifestyle, about exercise, about controlling sugar. So that's obviously an uninformed doctor who's doing bad things because they're not telling you about the metabolic syndrome. So I think that will be still the best, though it's not a very good worded question, but that happens sometimes, and sometimes confusing questions also come. So I think we should also attempt to answer those things as well. So we know PCOD will have a lot of role of this, because that one, you want to reduce insulin resistance at all costs in people. So simple question, not too much of discussion, because I don't think it's a very good question which was asked. Okay, all right. Okay, now one more question which was asked similarly. They always, INICET somehow is very pro PCOD questions. All right, 26-year-old woman, again BMI is high, infertility, hirsutism, acne, PCOD, everything is there. Ferriman Galway is a score for hirsutism. Okay, okay. Next line of management would be, now finasteride, metformin, ovulation reduction, weight reduction. Tell me the answer, bache. Tell me the answer, everyone. One second, give me one moment, please. One second, give me 1 second. 1 second, please. Yeah, okay. Tell me the answer now. Next line, the answer will be this: weight reduction plus try spontaneous. If it fails, go for induction. This should be because you have to do first lifestyle modification. That's always been important. Don't rush for drugs. Don't give them immediately ovulation induction, clomiphene, and no. We want to then ask the patient, ki, bhai, a lot of things are in your hand. Please do something yourself. Okay, please do something yourself. If it doesn't work, because see, you will actually be able to reduce everything just with weight reduction. Okay, and then many people can even conceive. If they don't do that, then you are justified in pumping ahead and giving them everything. Okay, don't immediately give them medication. That's an important guideline for all of you, right? Okay. Recombinant HPV vaccine is made from which antigen? Should be okay. This is L1. E6, E7 write down are for oncogenicity. Okay, oncogenicity. Okay, and L1 is for vaccine production. Okay, L1 is for, you have to know this, vaccine production. Also remember the Indian version, Sarvavac. Okay, which is produced by the Serum Institute of India. Okay, these are going to be, this is a quadrivalent. Okay, this is a quadrivalent vaccine. Quadrivalent means it's 6, 11, 16, 18 coverages. Okay, quadrivalent vaccine. Quadrivalent vaccine. Less than 15 years, give 2 doses. After 15 years, give 3 doses. Okay, 3 doses. Okay, and in 3 doses, it's going to be 0, 1 to 2 months, and 6 months. 0, 1 to 2 months, 6 months, and 2 doses is directly 0 and 6. 0 and 6 months. Okay, clear? All right. So this is the vaccine. This is the virus. Sorry. This is the one which we are going to use for vaccine production, right? And E6 and E7 are what are oncoproteins. Basically, they inhibit two things: P53, which is a tumor suppressor gene, right? And this is going to be E6 and going to be inhibiting the RBG, right? Clear? So this is what the inhibition that creates oncogenic potential, especially the cervical carcinogenesis. Okay. Okay. Now statement. This is the reason assertion kind of question, which has also been asked. Reason assertion questions, right? Statement 1. Histological examination of a patient with flaccid bullae, okay, and painful lesions show suprabasal splitting. Is this a painful lesion? Row of tombstone is seen in pemphigus vulgaris and is diagnosed. Let's see now. Okay, listen very carefully. The thing is, now tell me if the statement 1 is correct, yes or no. Okay. Histological examination of patient with flaccid bullae and painful lesions show suprabasal. Is it correct? Should be correct, right? Because this looks like pemphigus vulgaris, painful lesions, flaccid bullae, right? Row of tombstones is seen with pemphigus vulgaris and is diagnostic. Yes, correct. Now, so it's going to be either A, both are true, or it can be B, right? Now the thing is, row of tombstone, listen very carefully. Suprabasal blistering, suprabasal splitting, okay? This is the row of tombstone, okay? Row of tombstone, right? Now the row of tombstone is because, see this, row of tombstone is because the hemidesmosome doesn't break. Are you with me on this, please? Hemidesmosome does not break. Everybody okay with this? And the desmosome breaks. And this desmosomal breakage gives you suprabasal blisters. Yes or no? Okay, desmosome breaks and hemidesmosome doesn't break. Clear? Right. Now tell me this. Is the suprabasal blister the reason? Is the suprabasal blister? See the question, read. Both are true. 2 is the correct conclusion of 1. Do you think the suprabasal blister causes row of tombstones? Yes or no? Does the suprabasal blister cause row of tombstone? No. The hemidesmosome being okay and the desmosome not being okay causes the row of tombstone. No. Just by itself, a suprabasal blistering cannot cause row of tombstone. Imagine if your hemidesmosome also broke, then where will you get a row of tombstone? So the hemidesmosome not breaking is the main reason for the suprabasal, for the row of tombstones along with suprabasal blistering. Are you with me on this analysis? No? So this is going to be the second one. 2 is not the conclusion. Both are true sentences. But 2 is not the conclusion of 1. 1 is a suprabasal blister with flaccid bullae. You think the flaccid bullae is causing the row of tombstones? You think the painful lesion is causing the row of tombstones? No. Clear ho gaya? Yes. Okay. 18th. Again, somehow INICET loves DIF. So can you see the trend on DIF? Important. Novilumab, forget novilumab. Pruritic and articulation, this is very typical bullous pemphigoid. Can you see again 50-year-old man, bullous pemphigoid. Subepidermal blisters, again bullous pemphigoid. IgC3, again bullous pemphigoid. Clear ho gaya? This is obviously, no doubt about it. Should be easy, should be quite easy to understand, right? Clear? Pemphigus vulgaris is always going to be scaly. Is also always going to be flaccid blisters, and both of them will be fishnet pattern. This is a linear pattern of IgG3, so obviously you can forget novilumab in this. There's no point in remembering that. Okay? Okay. 19th, match the following. Match the following. Match the following. Vitiligo. This is a wood slam now. Very important wood slam now. Okay. Disease and wood slam. Disease and wood slam is what we want to pick up. Vitiligo. Vitiligo is going to be white. Okay. Erythrasma, typically coral red. Tinea capitis, green. Pityriasis vesicular, yellow. Always remember wood slam is again an important point. Okay, isme I forgot to give you the option, so sorry for that. Okay, but at least we know this. Okay, clear? Pink is in porphyria, where the urine and blister fluid will become a bit pinkish. Clear? The other colors, green, burrow in scabies, ash leaf macule is white. So this is all the wood slam that we have. Okay, in one slide you can now know all the wood slam. Okay, clear? All right. A 34-year-old multiparous patient with multiple sexual partners come with painless. Now, when you talk about painless ulcers, you only think about two things: syphilis, and we talk about donovanosis. Okay, there's nothing else which comes there. Nothing else which comes there. Listen. Okay. Now, when we talk about this, so it could be syphilis, good donovanosis. Donovanosis will always very typically have intense bleed. So bleeding is a signature sign of it's almost everything is going to be. This is going to be non-bleeding. In fact, we call this a non-bleeding painless ulcer. Clear ho gaya? Okay. So now let's see the first test to be done here. We are talking about more of syphilis. We will do scraping. Now VDRL will be done if you look at secondary stage. Secondary syphilis. We don't want to do it when there's a primary syphilis because VDRL will only come a bit later on. Gram stain is usually done if you think of chancroid. Giemsa stain if you think of donovanosis. Now, why is it not donovanosis? Because there's not enough clue for donovanosis here. We don't see just a painless ulcer is not donovanosis. It's very vascular. So until I get a leading question like that of a vascularity, why would I think of such a rare disease? One of the rarest disease, by the way, is donovanosis. Okay, so we don't want to really pick up that. But if it's painless, it's going to be just that. If you think of it being a painful ulcer, then what will you think? Painful ulcer, then you think of HSV, you think of chancroid. Very typical, HSV and chancroid. Okay, HSV will be grouped vesicles. Okay, there will be multiple soft chancres. This is going to be grouped vesicles. Both are painful. Grouped vesicles. Both these will have a bubo. Bubo is positive, which is a lymph node which is swollen and painful. HSV also has bubos. Chancroid also has bubos. Remember that. Bubo, very important. Okay. Pihu has asked why scraping. Okay, how will that help? Good question, bache. Good question. In syphilis, We do scraping of the ulcer. We do a smear, put it under a microscope called as DGI, dark ground illumination. DGI, dark ground illumination. ठीक है? DGI staining. DGI is dark ground, and that dark ground is a classical test that we do for syphilis. ठीक है? Clear हो गया? ठीक है? Clear? Everybody got this? Okay. 21. A lady comes with white vaginal discharge, staining the undergarments yellow. She is on oral contraceptive pills. pH is acidic, lactose is normal, there is no itch. Tell me the answer. I will wait for this. I want to wait. I want to wait for this, for you to come out with the answer. I'm waiting so that let's see if you can get this answer. Is it bacterial vaginosis? Is it candidiasis? Is it chlamydia? Is it physiological? The answer it is a physiological. Okay, see, I'll tell you why. Bacterial vaginosis will first of all have foul smell. Okay, pH will be high. So can you see pH is acidic? So that rules this out. Clear ho gaya? Plus lactobacillus is reduced. Clear? Here the lacto is normal. Because bacterial vaginosis will only come in females who will actually have some issue with the microbiome, the flora. Candidiasis will be white, but very, very itchy and very, very sore. So can you say there's no itching, no soreness mentioned? pH is definitely acidic, so that does match, but the others don't match. Chlamydia is also going to be a symptomatic vaginal discharge. It's not vaginal, it's actually more cervical. Okay, it's more cervical discharge. Okay, but it's symptomatic again. So physiological is when you have normal discharge, and that can happen in females who are on oral contraceptive pills. And how do you identify normal discharge? No itch, no soreness, right? pH is normal, lactobacillus is normal. So don't tell the patient you got a disease, it's not a disease. Clear? Clear ho gaya? And one more is no foul smell. Clear? Okay. 22. A diabetic female with bilateral brown pigmentation in the groin, which of the following is the correct match? Tell me the answer. Okay. Now this is basically an asymptomatic lesion which is called erythrasma. Interestingly, erythrasma is red in fair skinned people and it's actually quite brown in Indian people. So it is not, the word eri should mean red, but now this is not red. Okay, this is not actually very red. This is actually not very red. Okay, clear? Okay. Now this is going to give you coral pink. Ideally it should be coral red. So I'm not sure whether pink was ours or red was ours. Ideally it's called coral red. Green we know will be scabies, we already know that, or tinea capitis. Okay. Yellow will be Pityriasis versicolor. Blue is a normal fluorescence only, that normally it's blue only. Now typically erythrasma is always going to be in the flexure, so that again matches. It's going to be in the folds, axilla, groins, everything is going to be the fold, right? And that's going to be the typical erythrasma, which is a Corynebacterium minutissimum bacterial infection of the axilla and the groin space. Axilla and the groin space. Okay, clear ho gaya? Everybody able to understand? Yes? Okay. This is just to show you the coral red bache. The coral red fluorescence. Okay. Typically in females or males, in the axilla is coral red fluorescence that we already know for erythrasma. Okay. Okay. Now vesicular lesion. Tell me the answer bache. Are seen in. Vesicular lesions are seen in. Answer is this. Should be easy to understand. Okay. This is caused by Coxsackie virus. Okay, Coxsackie virus. It's going to be vesicular eruptions on the acral areas. What is the DD for acral vesicles? DD for acral vesicles, apart from hand, foot, down, right down, it's infant scabies. Okay, infant scabies. Okay, infant scabies. Clear? Infant scabies. Okay, this is going to be acral vesicles. Acral vesicles. So hand, foot, mouth. So how do you differentiate between hand, foot, mouth and infant scabies? Both are acral areas. Both are acral rashes. Okay, hand, foot, mouth and infant scabies. Hand, foot, mouth always remember has fever. No fever. Okay, it is very contagious. So is this. That obviously is the same. Both are very contagious. Okay, this is going to be hand plus foot plus mouth, inside the mouth. So that mouth is oral ulcers. There's no oral ulcer in infant scabies, and there's obviously a lot of itching in scabies, and you will not get that in hand, foot, mouth. Okay, roseola, dengue, measles are all exanthem. Exanthem means red rashes. We call them red macular rashes. Red macule means flat areas. The word macule means flat areas. Measles will always have some degree of coryza, meaning some upper respiratory infection, cough, and some kind of red eyes, suffusion of the conjunctiva. Clear? Right? Just to show you. This is hand, foot, mouth. This is, can you see the mouth? Inside the tongue as well. You can see the vesicular eruption on the acral areas. Hand, foot, mouth, usually in children, self-limiting disease with Coxsackie. Again, can you see the red rashes? The exanthem, this is called exanthem. Okay, it's again a self-limiting viral exanthem. Look at dengue. The dengue has two types of rashes. Okay, dengue has initially, in the initial stage of dengue, you will find a macular rash. Can you see the macule? Okay, and this macule has a very classical feature called as white islands in a sea of red. What do you mean by that? Can you see this white areas here? White area, can you see small white dots? So islands of sparing in a sea of red. Can you see this word? Islands of sparing in a sea of red is typically the dengue rash. Initially it is macular. Okay, later it becomes purpura and bleeding when the thrombocytopenia starts to come. Okay, initially it is macular, later on it is going to be purpuric. So there's two stages of a dengue rash. Okay, clear? Okay, this is the petechial late dengue rash, purpura and petechi, right? This is the late thrombocytopenic rash of dengue. Clear? Okay. 24. A child presents with multiple lesions on the thigh and the genital area. Lesions of umbilication. Histology has shown. Now this is the umbilication. Can you see this area? This is called the umbilication area. Basically, this area is what we're trying to show you. The umbilication area. You can see an invagination of skin. Can you see this invagination of skin? Okay. And from this invagination, the cells are coming out. And these cells I have already drawn have these Henderson-Peterson body. These are all Henderson HP bodies. This is the dermoepidermal junction, DJ. Okay. And in the epidermis, you have this molluscum bodies inside infected keratinocytes, also called as HP bodies, and they are leaking out. And from there, they are trying to infect other people. So it's called Henderson. Coilocyte we already know is there in HPV. Donovan body is seen in donovanosis. Donovanosis. Zang cell will be seen in pemphigus, as we already know. Okay, pemphigus, and we also see it in herpes. I've already drawn all that for you earlier, right? We have covered that. Pemphigus, single nucleus, single cell. Herpes, multiple nuclei inside a single cell. Donovan bodies. Then we know pemphigus and we know herpes, right? Clear? HP body, Henderson-Peterson body. I'm going to give you a chart again. Any umbilicated papule, if it says no internal involvement in this lesion, body is fine, then the answer will be molluscum contagiosum virus. If the question says some CNS involvement, then answer that as cryptococcosis. And if the question says some lung involvement, then the answer is histoplasmosis. Both these are AIDS defining illnesses, ADIs. This is even happening in normal people. Okay, so there are three differential diagnoses for an umbilical papule in dermatology: crypto, histo, plain molluscum. Plain molluscum, no internal involvement. Crypto, histo, very late stage HIV, very significant immunosuppression, CD4 very, very low. That's usually going to be the umbilical papule. Usually they are going to also be described as shiny papules. We also call them as dome-shaped papules. Okay? These are the words that we are now using. Dome-shaped papules, shiny papules of dermatology. Okay? Clear? Okay. There's the umbilical papule. You can see this. You can see this beautiful image of so many molluscum bodies. Can you see this red colored, eosinophilic, and they are now extruding out from the center, and that's a molluscum body. Clear? All right. This is the Donovan body, right? This is called the Donovan body. Okay, Donovan and Donovanosis. These are usually going to be dotted appearances on a low power, and on the high power we see a closed safety pin appearance. Closed safety pin appearance of the same Donovan bodies. And these cells have a name. We call them Pund cells. These are histiocytes, Pund cells, which have the Donovan bodies inside, and that's the Donovan body on Donovanosis, usually coming from Giemsa stain. Giemsa stain. Okay? Giemsa stain in Donovanosis. Clear? This is just to show you the vesicular eruption. We have seen all this history before. HSV2, grouped vesicles, and then you can even have grouped ulcers in this female, right? Very painful disease to have herpes genitalis. Look at the right side. This is what is called as a multinuclear giant cell, MNG, on a Zank smear. Okay, on a Zank smear. Okay, Giemsa stain is put, and then we can look at grouped ulcers, grouped vesicles. Drug of choice we already know is going to be acyclovir. Clear? Everybody okay? This is the HPV, human papilloma virus, condyloma acuminata. क्या कहते हैं? Condyloma acuminata, and the drug of choice for that, write down please, is imiquimod. Drug of choice for condyloma acuminata is imiquimod. Okay, it's usually caused by HPV6 and HPV11. You can see the coelocytes. Coelocytes, okay, are perinuclear halo cells. We have drawn this earlier. Perinuclear halo cells, okay, inside infected keratinocytes. Okay, this is basically the viral infected keratinocytes. Okay, clear? Okay, also write down drug of choice for verruca. If the question comes like that, madam, the non-genital watch, it's going to be salicylic acid. Okay, it's going to be salicylic. So वहाँ पे अपना salicylic mark करना है. Condyloma acuminata, which is a type of HPV infected genital lesions, and that's going to be imiquimod. Imiquimod. Clear? Okay. 25, please. A young man presents with linear lesions as shown. All the following can cause this along lymphatics except. This is very, very typical, very, very typical lymphatic spread of organisms. You can see this nodules. Can you tell me the answer, bache? Nodules along the lymphatic spread. Can you see this lymphatics? Nodules along the lymphatic spread. Sporothrix can cause it, nocardia can cause it, marinum. So the answer is going to be staph. Okay, so this is a slide that you have to mug up. So the three diseases which can cause this. Okay, nocardia can cause it. Sporothrix, which is sporotrichosis, or Mycobacterium marinum. The disease is called fish tank granuloma. Okay, fish tank granuloma, also called as swimming pool granuloma. Also called as swimming pool granuloma. This is sporotrichosis. Sporotrichosis. Staph aureus obviously cannot cause this kind of a disease process. Okay, clear? Okay. This is a repeat question, but okay. Progressive lesions. There have been two questions on BCCs. So there's one more ulcer. We have almost discussed this before, so it's a repeat question. There's a basal cell cancer, rodent ulcer. Typically, we'll not discuss it anymore. Already finished it earlier in one more question that we had. But just to show you the another image for BCC with an edge which is like a eating of a rat. Okay, so no discussion on this. Important question. This was an unusual question. I think have to give you a bit more information on this. A female with history of Raynaud's phenomena, skin thickening and breathlessness present with skin lesions as shown. The following best represents it. Okay. Now, if I just zoom in, so first of all, Raynaud's phenomena. So that's obviously episodic vasoconstriction of your digital vessels, giving you blue digits. Okay, giving you blue digits. Okay, skin thickening. So this skin thickening is called sclerosis. Now, systemic sclerosis is the likely because there's breathlessness, which means inflammatory interstitial lung disease, skin lesion. Now, let me zoom in. In this skin lesion, can you see alternative areas of dark and brown, dark and white, dark and white? So, this dark and white has been called as salt and pepper, and which is a sign of systemic sclerosis. Okay, leukoderma is also called as contact leukoderma, for example. That will not be like this, right? Okay, that'll be like a bindi thing, or that'll be like a slipper with PPD thing, right? Or hair dyes with PPD. So that's going to be in a pattern. Vitiligo is not going to be alternative, regular white and brown, white and brown. Contact allergy is not possible because there's no itching mentioned. So this is called as salt and pepper. It's a unique feature of systemic sclerosis. Unique feature of systemic sclerosis. Clear? This is just to show you some other features of systemic sclerosis. We call this pursed mouth. So the mouth is very small, like a fish mouth, very small, right? There's going to be usually tight skin on the face, very tight skin on the face. This is going to be digital ulceration. Okay, digital ulceration. Okay, this is because of repeated Raynaud's phenomena. Okay, there's going to be a lot of lung involvement, and this is sclerodactyly. Sclerodactyly. The finger is going to be very tapering. Okay, it's going to be very pencil like. Okay, very pencil like. And they also have issues with deglutition. Okay, issues with inability to eat. Okay, inability to swallow because they have esophageal issues. Okay, all these are features systemically, but skin wise you'll usually see digital ulcerations and Raynaud's phenomena. Clear? All right. 28. A patient presented you OPD with blackening of the hands, amoebic descensive, for which they took medication. What would be the reason? It's very typical fixed drug. Amoebic dysentery means you're going to take usually tinidazole, ornidazole, or metronidazole, right? Now these are common drugs to create this blackening. This is called the dermal pigmentation. Simple question this, dermal pigmentation. Okay, and that's called fixed. Why? Because it'll keep on coming on the same site again and again and again with re-exposure to the same drug. Allergic contact, why not? Because this will first of all be itchy and oozing, right? This obviously not. Atopic dermatitis will not be something like this, right? It's not nothing to do with dysentery and all that. Usually atopic dermatitis in adults will be flexural oozing eczemas, right? It may flexural oozing eczemas. So obviously it's not that. So obviously it's going to be very typical fixed drug eruption. Clear? Okay. Which of the following is a scarring? This we have done. Sorry, I think it's a repeat question. We've already done it. So I think it's been mistyped and again given. So we'll skip this question. Okay. Now this is an important question. A patient present with itchy white lesion on the genitals as shown. Likely disease. Now look at the options. Now forget about page edge. Now lichen sclerosus, vitiligo. Now lichens will be usually purple. Okay, so that again is unlikely. So you have to decide between vitiligo and lichen sclerosus. Now vitiligo is never itchy. So that straight away tells you there's something different here. This is called lichen sclerosus. Okay, which is a condition of inflammation, okay, of the genitals, for example. It can be both in males and females, It typically causes sclerosis of the genitals. Sclerosis means, I'll remove my own figure from here so that I don't crowd out the slide. Sclerosis means it's going to be very tight skin. So the introitus is very tight. Okay, and it prohibits sexual penetration. It's going to be very itchy, inflamed, and these are usually pre-malignant diseases. It can predispose people to malignancy. This is going to be white and sclerosed, often with telangiectasias on these areas. This is called, like, it's an idiopathic condition. Some people have a role for Borrelia as a cause for this, but you have to be watching out. Treatment is usually going to be topical steroids or topical tacrolimus to reduce the inflammation and prevent the progression to malignant state. Okay, that's what we would know, right? Clear? Okay. Now 31. A patient presents with recurrent itchy erythematous plaques over scalp and sacral areas, history of joint pains, nail finding. This is very easy, should not be difficult. So can you see, INICET questions are not very difficult, but what happens is when you put these questions into the scenario of time constraints, when you're stressed in the exams, and then you say, "Arey, aage badhna hai, aage badhna hai." So sometimes even in the simple question you are trying to make a mistake. So the point of this INICET questions and the discussion is going to be so that you know कि भाई इतना कुछ difficult नहीं है, इतना difficult नहीं है जितना हमें लग रहा है, ठीक है ना? So itchy erythematous plaques, scalp, sacral areas, joint pain means obviously psoriatic arthritis, right? Should be, and this is the nail finding, clear? Digya, nail finding, right? And this nail finding is usually going to be pitting, okay? Salmon patch, thick nail, and onycholysis, the nail separates, okay? So this will be typically, psoriasis should not be difficult to understand, okay? Everybody clear हो गया? Okay. Usually we remember it by the word spot, okay? Salmon, pit, onycholysis, and thick nail. Clear? Okay. Now farmer comes with nodal lesions on the foot, microscopy. This again is quite simple. This is called the sclerotic body. This was asked, okay, and they had given you this question. Nodal growths mean these are, if you see this foot, it's going to have a lot of these nodular growths, and this is going to be called as chromoblastomycosis. Okay, chromoblastomycosis, chromoblastomycosis, right? Everybody understood? Tell me the answer, please. Tell me the answer. What is the answer on this? Just give me 1 second. Just 1 second, please. There's somebody here. Just 1 second. Give me 1 second, please. Okay. So sorry for that. Now answer, see this now. Now blood invasion is common in those with malignancy, no. Dimorphic is you'll talk about sporotrichosis here. Okay, this is sporotrichosis. It's a dimorphic fungus, right? This is not sporo, right? So answer should be this. Because interestingly, this happens in mycetoma. Remember this. Invasion, okay? Invasion of fascia tendon muscles is very typical for mycetoma. In chromo, you don't have any invasion of underlying structures. Okay, slightly tough question this actually. So the answer is going to be third. Okay, dimorphic, you're not thinking of sporotrichosis. Fascia tendon muscles is going to be usually seen in mycetoma. Okay, clear? Okay. Okay. We have about 15 more questions to go. Okay, Vijay? A patient with satellite skin lesions present to you. He also has one hypopigmented lesion and one thickened feeder nerve. So one skin lesion and one thick nerve. Okay. Now, according to the old guidelines, this should be usually possibacillary. But according to the new guidelines, there's going to be multibacillary. So it's going to be packet B. Okay, this is multibacillary. I hope you know the new guidelines. Okay, so we don't want to discuss it. We already finished it inside the class. Okay, so we know that zero thickened nerve. When you talk about nerve, zero thickened nerve is PB. One or more thickened nerve is MB. Okay, 1 to 5 lesion is PB. More than 5 lesion is MB. Okay, and negative SSS is PB and positive SSS is MB. Everybody okay with this? Okay. All right. Match the following. Match the following. Silvery scales in psoriasis. Brany scales, Pityriasis versicolor. Mica-like scale is a condition called as PLC. You have to mug up this. Mica-like and Colruyt scale, Pityriasis rosea. Colruyt scale, Pityriasis rosea. Clear? Pityriasis rosea. So it's going to be this, the D one. Okay. Now, apart from that, we already know about carpet tack scale. That's DLE. Yellow greasy. That's seborrheic dermatitis. Fish-like in something called as ichthyosis. Fish-like in something called as ichthyosis. Okay. Mica-like means that it looks like mica. It looks like mica. You have to mug up this mica-like scales. Mica-like scales in a condition which is a chronic disease called as Pityriasis lichenoid. Not too much to know, just about the name. Mica-like scales. Okay. Okay. A forest worker history of cauliflower lesions. Cauliflower lesions. Forest worker has cauliflower lesions. What he calls. So can you see this? Chromo has been asked too many times. Sclerotic bodies. Sclerotic bodies. Okay. Splendor-Hopley phenomena is asteroid body seen in sporotrichosis. Okay. So this is very typical brown bodies of chromoblastomycosis. Should be easy to understand. Okay. Now this is going to be faster now for us because theory we have all done. So it's a repeat question. Can you see the INICET actually repeats many questions? Okay. So the reason I've given you second version of the same MCQ, meaning the same MCQ has been asked in two different ways. So I'm not skipping that. I didn't say that, okay, this has been asked before, so I'll not repeat it, but just to show you that repetition happens. All right. Patient had lesion as shown. Patient mentioned that a spider crawled on that area while sleeping. Diagnosis is. Now, a lot of people will think of this as a spider bite itself. But this is typically a dermatome lesion. Patient might say that it's a spider bite, but you should not as a doctor think like that. You should think of this as, a lot of students said irritant dermatitis because of spider crawling, because they said the patient told you. The patient is not educated, right? Patient can tell you any damn thing, but you are not supposed to believe it. So this is basically a grouped vesicle in a dermatomal fashion. So obviously it's going to be herpes zoster, also called as shingles. Most common complication, write down, of herpes zoster is going to be PHN, post-herpetic neuralgia. Post-herpetic neuralgia. Post-herpetic neuralgia. Okay? So this was a trick question, right? Because this mentioned spider and then you kind of said irritant contact, allergic contact. No, it's herpes zoster. Okay? Chicken pox will be almost the same disease but over the entire body. Okay, and chicken pox is typically a central rash, not an acral rash. Okay, like remember I told you that infant scabies and hand foot mouth, these are acral vesicles. This is not acral vesicle, the central rash, center body area without even being on the edges. Okay. Okay. Now 10-year-old present with arthritis of the knees and lesions on the hand is shown. The diagnosis very typical Gottrons. This is Gottrons, and this was again asked. These are purple red areas on the metacarpophalangeal and interphalangeal joints in those with this disease called as dermatomyositis. Dermato and myosite, two components. So here in the derma component we have Gottrons papule, we have something called as shawl sign, and we have something called as heliotrope rash. Heliotrope rash. And the myositis is proximal muscle issue, proximal muscle weakness, and myositis. So these are the three things that you will have to know, right? 38. Patient from Bihar had history of high-grade fever, symmetrical lesions, without nerve and without sensory loss. Tell me the answer, bache. Tell me the answer. High-grade fever. Okay. So this should mean visceral leishmaniasis or Kala Azar, right? And this leads to be post Kala Azar. No nerve involvement, so no leprosy, right? No sensory loss, so no leprosy. So this should be PKDL. Clear? Now remember, LL also has no sensory loss, right? But interestingly, LL will have thickened nerves. When it says no nerves, that is a clue. Plus, LL will have no fever history, no? Like the one which is mentioned. Why high grade fever, right? That should not be true. So you should not think of this as LL because LL does have normal sensation, but has thick nerves and has no relation to fever. So PKDL diagnosis comes from GIMSA stain to look for LD. Don't confuse this with Donovan body. This is not Donovan. It's Leishman-Donovan, right? And treatment is usually oral miltefosine. Oral miltefosine. Everybody cool? समझा? समझ गए हो? ठीक है. This is what BL answers means, bilaterally symmetrical patches, but this can also easily be PKDL. Images between borderline lepromatosis and PKDL look the same. This is, for example, PKDL. Can you see similar images? Again, as I said, no thickened nerves, no fever in the past. All those differentiating factors are always there between PKDL and leprosy. Clear? All right. 39. A 65-year-old man presents with itching, arterial lesion, and bullae on red as well as normal skin. So again, can you see bullous pemphigoid is an important topic. Remember, DIF was an important topic. Remember chromoblastomycosis. Can you get the trend now? This is very typical. They like herpes, for example. They like Zang, for example. They like molluscum. These are all standard questions for INICET in dermatology. Okay. Now itching, arterial-like lesions, old man, right? Normal skin, red skin should be easy. No issue on this bullous pemphigoid question. Okay, clear? Okay. There's the classical bullous pemphigoid, red skin, background, blisters which are typically tense, and as I said, full of eosinophilic infiltrates, subepidermal, non-acantholytic blisters, and these blisters will be very typical in an old person. Okay. Okay. A female comes with unilateral lesions as shown. Leukotrichia. Diagnosis is. Now the question was, is it focal vitiligo? Is it segmental? What do you think? Tell me the answer, bache. There's going to be one lesion here, one here. So tell me, is it focal? It's an important question because a lot of students answered it wrongly. This is typically segmental. Can you see segment, please? Segmental, coming in a straight, you can connect it in a straight line. तो इसको हम कहते हैं, क्या बोलते हैं? Segmental vitiligo. Segmental. So focal will only be a small spot. Now pybardium is not likely because it's going to be congenital, typically on the forehead. You don't have to know too much about it. Okay. Again, there's a birthmark, right? Right. So here, and leukotrichia again would look like it is vitiligo. So we'll answer it as segmental. Okay, clear? Okay. Now this is just to show you the segmental. It's usually unilateral, one side, but focal cannot be connected like that. It's not unilateral. You cannot connect focal in a straight line, but you can connect segmental in a straight line. Clear? Okay. Adult. So last 6 MCQs to go now. Adult presents with itchy hyperpigmented plaques on the with exudation. The word exudation means oozing. The word exudation means oozing. Flexure of the elbow and back of the knee. Can you see the back of the knee? Back of the knee, right? Typically flexural involvement, oozing involvement would typically be atopic. Flexure would usually, the psoriasis would be on the extensor, will be not oozing. Clear? Should be easy, right? Flexural and oozing. Exudation is your pickup word. Never forget that pickup word. Exudation, atopic dermatitis. Okay? Clear? Okay. This is what we mean. On the in adults, it usually comes on the flexure. That's what you remember. Flexure, flexure. In children, it usually comes on the cheeks and extensors. This is, and oozing is there in both. Oozing is there in both, right? But infant, the area would be different as compared to what adults will have. Clear? All right. A patient present with lesions as shown. Diagnosis. Now tell me the answer, please. Important question. This was again asked. Tell me the diagnosis for the. Look at the image. We already discussed it earlier. Can you appreciate the annular ring lesion without a scale? Can you pick that up, please? Without a scale, this is typically borderline Hansen's. Okay, it's borderline or mid borderline. We also call this punched out lesions. क्या कह सकते हैं? Punched out. ठीक है? Punched out lesion, we also call it inverted saucer. Okay, inverted saucer, punched out lesion of dermatology, annular lesion of dermatology is all something that we do. Okay, clear? All right. A child comes with patchy hair loss, itching and scaling on the scalp. Now, the moment you have patchy hair loss in a child, you should always think of tinea. It's a giveaway question. Tinea. Hair loss because there's easy pluckability. Itching is there, scaling is there. Scaling, okay, usually would be gray patch. Itching, so answer would be tinea. Right, KOH, right? Obviously, no doubt about this, right? Clear? Drug of choice for tinea is oral griseofulvin. Oral griseofulvin. But for all other teneas, apart from tinea capitis, never answer griseofulvin, answer terbinafine or itraconazole. Terbinafine or itraconazole. ठीक है? Terbinafine or itraconazole. Clear? Okay. Match the following, again very important. These are the STD kits bache. STD kits. So I'll show you on the kit only first here so that you can extrapolate it on the table. Gray patch, gray kit, sorry. Urethral discharge, cervical discharge. ठीक है? Cervical discharge. This has usually cefixime plus azithromycin. Okay. The green kit is for vaginal discharge. Okay. It has secnidazole plus fluconazole. Blue kit is for genital ulcer NH means non-herpes. General ulcer, non-herpes. Okay. This usually has, this is people who are allergic to penicillin. Allergic to penicillin. ठीक है? It has usually doxycycline plus azithromycin. This is genital ulcer herpes. Okay, I'll remove myself from here first. This will have only acyclovir. This is inguinal bubo. Okay, this has doxycycline plus azithromycin. This is a yellow kit for lower abdominal pain, LAP. This has cefixime, metronidazole, and doxycycline. In this, I don't have the white kit, which will be for genital ulcer, non-herpes again. Okay, that will have benzathine. I'll maybe write it somewhere. I don't have space. Maybe I'll write it here. White kit. Okay, that's got benzathine penicillin plus azithromycin. Again, genital ulcer, non-herpes. Genital ulcer. These are your kits actually for STDs. I hope you understood this. Okay. Now let's go back. Green kit is for vaginal discharge, gray is for urethral discharge, yellow lower abdominal pain, white is genital ulcer, non-herpes. Clear? Bubo should be the black kit, this should be the red kit. Everybody okay? Somebody's asked me to go back to option number 1 and 3 in question 35. Let me just go back to 35, bache. Option 1 and 3. No, we don't have to know about this. Basically, what we know is when we talk about microbiology aspects, okay, we'll usually only have to know mycetomas, chromoblastomycosis, and sporotrichosis. Okay, so for sporotrichosis, we know it's a spandrel hapley phenomena, and here it is this. And in mycetoma, we have basically the Madurella mycetomatis, okay, which I told you, and second one is that's a bacterial colony. So this is not relevant in any of our fungal infections and deep fungal. It's nothing to do with dermatology part here. Okay, got this? Okay. Always come with BB and BL. BB and BL. Okay. Now BB. Now very easy. BL, remember, is always described as almost symmetrical. Almost symmetrical lesions. Can you see this almost symmetry? Okay. Can you see this? Also remember this as uncountable lesions. Can you see the number? Too many. Go back to, where is that BB image? I'm just trying to find the BB image. 1 minute. Huh? Where was the borderline image? So there is no confusion. It's a typically punched out lesion. You will not call it as almost symmetrical. You will not call it as almost symmetrical and multiple lesions. It's going to be typically going to be circular lesions. Okay. But in question number 35, there is no subcutaneous mycosis. Okay, which will come with those things. It's going to be usually a different systemic fungal infection. Those are called as systemic fungal infections. In skin fungal infection, we don't find any of those option 1, option 3. Okay, so mycetomas don't create that chromo. So from a derma point of view, we don't have to worry about 1 and 3. Okay, those are different. Those are called as systemic fungal infection, usually happening in immunocompromised people, for example. Okay. Okay. Question number 45. A patient presents with painful ulcers on the glands. This we already discussed, bache. This is going to be 1 and 2. This is going to create urethral discharge. This is again urethral discharge. So ulcers will only be 1 and 2. We've already discussed it, so I'm not going to do it anymore. Rahil, bete, follow what all guidelines now are. Whatever I told you is what you're supposed to follow. Forget about who's given it and who's not given it. WHO, NACO doesn't really for leprosy. It's going to be standard. Whatever I told you is standard. Okay, that's what you will follow. Sojanya, no, herpes is बच्चे not curable. Okay. There's a chancroid, multiple painful ulcers, soft chancres. ठीक है? HSV grouped vesicles, we have seen these images before, right? Grouped ulcers, we have seen this image before of herpes as well. ठीक है? Clear? Urethral discharge either gonococcal or non-gonococcal. Gonococcal will be usually thick pus, purulent, and non-gonococcal will be much thinner, mucopurulent discharge. ठीक है? Clear? So this is looks like gonorrhea here. I told you about multi-drug resistance issues with MDR. ठीक है? Clear? Okay. What all seen in chancroid? Bleeding, painful, groove sign, school of fish. Now typically groove sign is seen in LGV, lymphogranuloma venereum. Okay, 1, 2 and 4. 1, 2 and 4. Okay, 1, 2 and 4. Clear? Okay. We have done this, so we'll not discuss this too much. Okay. Now, sorry, 47. A farmer presents with foot swelling with discharging sinus, likely diagnosis. Now, whenever you have a foot swelling, see how you go ahead for that. See, whenever you have a foot swelling, I'm going to make a chart for that. If the question says it's going to have a sinus plus a grain, always mark it as mycetoma. Foot swelling minus sinus minus a grain, but with a sclerotic body, mark it as chromoblastomycosis. If the foot swelling is with sinus, without grain, plus moving along lymphatics, okay, that's going to be called as sporotrichosis. That's it. You just have to know these three. Okay, this foot swelling is usually going to be in a farmer, right? And it's going to be after a thorn prick. Clear? Everybody okay? Okay, so this, see this, foot swelling plus sinus, foot swelling plus sinus. So is this sporo or is this mycetoma, right? Now it is not going to be, can you see it's not moving along the lymphatics? It seems to be a local foot swelling. So then this should be, because along the lymphatic the movement has to be there. For example, it has to be something like this. Can you see this? It's moving around the lymphatics, right? That's going to be sporo. And there's the grain in people who have mycetoma. Grain in people who have mycetoma. Clear? Right? Okay, fine. So this then completes exactly what I want to do, right? Okay, so we have finished on time, 2 hours, exactly what I thought. Okay, we did 5-year questions. Now we did 5-year questions. Okay, all the actual MCQs we have done. Okay, all things I've included, right? We started from the November 2020 exam. This is where we started. Okay, and we went till the recent most 2024 question, right? So we've done 5 years of dermatology. Every MCQ has been covered. There's nothing which comes out of this. Okay, question number 16. Okay, let me just check 16 bache. 16. Yeah, what happened 16 bache? Is there some mistake on that? E6. Okay, so let me check that. I'll just check that, please. Okay, if there's an error, I'll let you know. Okay, Dr. Billu, is that you think that's an error on that? I'll let me cross check that. Okay, yes. All right, so good. So Okay, bache, okay. Okay, thank you for that correction. Thank you for that correction. So thank you so much. Did you enjoy how we did this? So every session is different. In the vibe session, in the one shot, we do it very differently. Okay. Strategy, bache, always remember that INICET is an exam which always rewards you for present moment thinking and having a clear head. So what you should really work on is giving a lot of exams. Try to be not very stressed. Try to give it as much clarity of thought as possible, because you sometimes, you will think of one and then mark something else at the end. So that is something that is there. Okay. Uh, so Rahil, thank you for that correction. Yes, please note that correction. I think the typing was incorrect on that. Okay. Right. Okay. So I think everything is okay. Everything is good now, and I hope you are able to now do this. And what I want you to do is just revise dermatology like that. Okay. Okay. We'll see that. Okay. Chalo. So good. So goodbye. Take care. Anything else that you want me to clarify, bache? Anything else? Please ask me your questions. Dr. Billu, I'll check Robbins. I'll check Robbins, though I don't read Robbins, obviously, but I'll check. I'll check Robbins. Okay. Thank you so much for that. Okay. ठीक है. चलो. So that completes. Thank you so much for your patience.